Hello friends, we are going to read about the atrial fibrillation today. Atrial fibrillation. So, it is the most common cardiac rhythm disturbance in clinical practice. So, it is the most common cardiac rhythm disturbance in clinical practice. So, we have to learn one thing. If what is there in AF is P wave is absent plus the rhythm is irregular, so this comes to be AF. But what happens if P wave is absent but the rhythm is regular? It is not AF. It is not AF. It is AV nodal reentrant tachycardia. Okay, so broadly AF is classified into 4 categories. We are going to read about this. First is paroxysmal, second is recurrent, third is persistent, fourth is permanent. So paroxysmal is what resolves spontaneously. Recurrent is 2 or more episodes of AF is there, then it comes into recurrent. Persistent if the AF is present for at least 7 days, and permanent if the AF is present for at least 1 year, then it comes to be permanent. Mostly patients are of more than 75 years of age with underlying cardiac disease, but approximately 25% of patients are of less than 60 years without any cardiac disease. So these patients with of less than 60 years of age without any cardiac disease are having AF. The AF is known as lone AF. Okay, one entity is there, post-operative AF. It is very common if there is cardiac surgery. If cardiac surgery patient is there, the patient has gone cardiac surgery, approximately 45% of cardiac surgery patients experience post-op AF. Approximately 30% of patients of non-cardiac thoracic surgeries experience AF, and approximately 8% of patients of other major surgeries experience AF. Usually it appears in first 5 operative days. Usually it appears in first 5 post-op days, and it is associated with long hospital stays and increased mortality. What are the predisposing factors? The predisposing factors are heightened adrenergic activity. Second is magnesium depletion, very important. third is oxidant stress. Okay, so as magnesium depletion is a predisposing factor, so prophylaxis with magnesium and beta blockers are common. So post-op, if you are giving magnesium, then the chances of AF is minimum. There is evidence that N-acetylcysteine, it is an antioxidant. It provides effective prophylaxis following cardiac surgeries. Prophylaxis for AF. Okay. Most of the post-op AF resolves in few months, so they are not permanent. They resolve within a few months. What are the adverse effects, adverse consequences of AF? Very, very important. There are two adverse consequences. One is impaired cardiac performance, and second is thromboembolism. So what happens in impaired cardiac performance? The atrial contraction is responsible for 25% of the ventricular end diastolic volume in normal heart. So if the cardiac function is normal, if the cardiac function is abnormal. So if the cardiac function is normal, then the loss of atrial contribution to contract ventricular filling in AF has little noticeable effect. But if the cardiac function is already abnormal, then there is significant decrease in stroke output when diastolic filling is impaired by MS or decreased ventricular compliance. So when the cardiac function is abnormal, then there is a significant decrease in stroke output when diastolic filling is impaired by MS or decreased ventricular compliance. This effect is more pronounced at increase of when there is heart rate is increased, as when the heart rate is increased, then decreased time for ventricular filling. Then there is decreased time for ventricular filling. The second adverse consequence is thromboembolism. So the thromboembolism, okay, if predisposed to thrombus formation in left atrium, so these thrombus dislodge and embolize in the cerebral circulation. What causes these thrombus dislodge and embolize in the cerebral circulation, and this dislodgement and accumulation in cerebral circulation leads to acute ischemic stroke. Okay, so the patient with AF is 3 to 5 times has higher incidence of stroke. Very important. So we will read about the management of AF in